We'll open the panel up to questions now. I'm going to request that we have one question per person so we have an opportunity to go around. There are mobile mics going around, so just indicate if you have a question and we'll bring the mic towards you. Yes, please, thank you.
So how hard is it for a patient with high HLAs to get a transplant? I've told I wasn't a candidate because of it.
Yeah. So my mic is on. Folks can hear me, right? Okay, good. So HLA it's the proteins. It's actually that bind to that HLA. So HLA is the markers that are on the cells in our body that identify us as us, right? So it's the way that your body knows that if you get an infection, like that's not one of you, it's not supposed to be there, and your body attacks that bacteria and gets rid of it. Unfortunately, it's also the way that your body knows that that's not the lung you were born with. And so if you have a lot of immunoglobulins to that HLA, then it is possible that you can not have a donor that would work at all in you. So unfortunately, and typically, that affects women more often than men, because having babies is a risk factor for getting some of those unacceptable antigens. The other thing that it's highly associated with, though, too, is underlying connective tissue diseases. So autoimmune diseases seem to kind of fuel that process. So the challenge in it is that depending on who looks at it, you may get slightly different answers. So I suspect that, unfortunately, you have a lot of it, and that it's a big, big issue. And so the likelihood that someone else is going to look at it and see something different is probably very low. But probably very low is not the same thing as absolute. So depending on the center's practices, too, centers might have some strategies where they try to affect that. So the center that told you that that's not, that they're not going to be able to help you, it's also reasonable to ask them, so is there anybody else that can? And it's reasonable to ask, is there anybody else that can look at that stuff? Is there some place that maybe they do more things that are associated with that? It is a really tough problem, though, unfortunately.
I just wanted to make a comment about that because I'm here.
Yep, there we go. Okay, yep.
I'm being evaluated, and I've been evaluated, and I had high antibodies. I had, at the one center, 98% PRA.
Yeah.
So I was kind of told, no, but I went someplace else. They said I only had 50%.
Mm-hmm.
And they also said it depends on the particular antibodies that they are.
Mm-hmm.
So now it's looking promising. So I wouldn't always, like he said, take that as a firm no.
Yeah.
I also have B negative blood, so I've got two things not going for me. Anyway, think I'm going to get on the list. And
that's the thing that you mentioned, the panel reactive antibody is a PRA. So if you have a PRA that's 98%, then that means that in theory at least, that 98% of the donor pool, your body will react with it. So there's obviously a big difference between a PRA of 98 and a PRA of 50, right? You have to have 100 passes, and there'll be 2 potential donors, and then depending on who's above you or not, right, versus 1 out of 2. So, and that is something that is decided by each center. So that criteria for those HLA unacceptable antigens, it does vary from place to place. So again, It's reasonable to ask. It's always reasonable to ask. You may not get the answer you want, but it's always reasonable to ask.
So Dr. Whelan, within the context of the HLA and the PR4 antibodies, PR3, for patients who get pushed back initially at some of these centers, would you encourage early evaluation at multiple centers to maximize the chances of lung transplantation?
Yeah, it's hard because I think, and the transplant recipients, all of them that are in the room, actually, I think are worth asking that question too, honestly, because so I'm in South Carolina. We're the only transplant center in South Carolina, and many of my patients access to another center. The reason why we built our center and program was so that patients could have access, because the next closest center to them is a lot of miles away. It's a tremendous amount of resources. The 12 oxygen tanks I mentioned for that one patient, if they had to go somewhere that was farther away, I'd be afraid to be behind them or in front of them, I guess, in the car. But at the same time, I would tell you, you do what you gotta do. So it's the reason why I said if a center is saying things to you and it resonates with you, that's okay. That's actually, even if the answer is a no, but that resonates with you and you feel like that's a really good decision for you, then that's a good decision for you. But if it doesn't resonate with you and you have the ability and you can figure it out, then I think asking other programs is a very reasonable thing to do. Every transplant physician, every single who's my age, every single transplant physician who is my age has either transplanted someone that their good friend turned down at a different program or had a patient that they turned down and got transplanted somewhere else. That is true.
Yes, please.
Yes. If you're turned down at one center and you go to another, do you start back at square one, or is there part of this testing that carries over?
So I'm hoping that the answer is no, you don't square one. You're at square, if there's 100 squares, you're at like square 10, maybe. So unfortunately, all those consultations and all of that, right, that evaluation and that discussion that really needs to be had by that transplant center, they want to make sure that you're knowledgeable about transplant. So the transplant coordinator has got to give you their spiel and make sure that you're fully educated. So you go through a lot of that. Hopefully they don't put you through the invasive testing. We accept other centers' invasive testing. Unless we really have a question about it, unless we're questioning the result, we generally accept it. But the time, I mean, to me, it's time. It's the same thing, clinical trials. I often say the biggest challenge of clinical trials is time, right? So that getting through that referral and evaluation and everything, that's all your time. That's the biggest cost, I think.
Yeah, so I'm from the University of Chicago, and we always encourage patients who come for initial transplant evaluation to come with as many records as possible. Whatever's been done, the most important test is the one that's been done already. You don't want to reinvent the wheel. So I think that's a very important point. Yeah. More questions?
On that note, my brother just went through a transplant 3 months ago, and he had high antibodies. Fortunately, the hospital that was near him, had the threshold where they would consider him and things. So, that's just encouragement to look elsewhere if some centers aren't. So, my question is there was some mention of the short telomere impact on survivability of a transplant. Could you kind of elaborate on that a little bit?
So there is a small series that's out there that shows that if you have short telomeres, your post-transplant outcome, you're at increased risk for chronic lung allograft dysfunction, which is a terrible way of saying that you have small airways disease after transplant, typically. And so it increases your risk of that. And then short telomere also is likely a marker for how well folks will tolerate immunosuppression. And so we have kind of a, I think we're getting better at this, but we do still kind of have a one-size-fits-all when we talk about how we're going to immunosuppress people. So we think if you're 25 years old or you're 75 years old, that immunosuppression plan should probably look different. The immune system acts differently the older that you get. And so short telomere is a marker that maybe that immunosuppression, maybe it should be a whole lot less, is a current hypothesis. The challenges of that, though, it's not really known very well. And so again, depending on where you're standing, some people may feel more strongly about that in one center than another. And then I think one of the other challenges that I often face in the clinic when I'm talking to a patient is that many times there's not like one thing, right? If you had one horrible thing and there was a reason why, I could just be like, yeah, that's the one reason why we can't do this. That's actually easier for patients to understand typically, and it's easier for me to get out. Things like short telomere or these other things that we can find in evaluations where we just kind of start stacking up things, that's when it gets a lot harder to explain to folks that that's the reason why we're turning you down. It's not really any one thing, but it's maybe a combination of these things, and so we think that that risk is too great.
So the PF experts have come to know that the earlier you refer, the better off it can be for patients because you have the ability to follow their progression. What do the patients do who are in a situation where their pulmonologist refuses to refer them for transplant?
Yeah,
get a different
So
pulmonologist.
yeah.
Refer yourself. You can refer yourself. We'll take calls. Yep. It's only harder because it's sometimes harder to get the records. But no kidding, like the record picture I showed you, like if you refer yourself, you're actually taking the initiative. That is something that we really appreciate. Transplant centers appreciate that. We want folks to take ownership of their care. So you referring yourself is way good, way good. And then yeah, maybe convince your pulmonologist to have a different point of view, because you would if you can do that. You would be helping many other people, not just yourself. So,
one of the questions, so just real quick, you showed a picture on the screen during your slides, and you referred to the fact that the gentleman who got a transplant, you were pleased that he had a hat, a wide-brimmed hat, on the beach and while he was on the tennis court. So that might have washed across us a little bit, but can you just throw more light on that? And
when you're parasailing, I noticed too.
Thank you. Thank you, Doc. Thank you.
Yeah. So you're at a substantially increased risk of skin cancer from the immunosuppression that we give. So and being in South Carolina, and I said I like to fish, so I will tell you when I go fishing, my son actually kind of picks on me a lot, but I have the whole thing on my face, and I have the wrap, and I have a long sleeve shirt, even when it's 100 degrees out. It's hugely, hugely important. Unfortunately, the immunosuppression really increases the risk of skin cancer.
Yes, please.
Yes. What do you do when your wife absolutely hates your hat?
I love your hat, and
I love it
and
Safety first. Safety first.
No, the question actually is, I was looking at the data on your patient, and I guess I'm kind of confused because it seems as though for years, like maybe 8 years, that his diffusion was around 10-15%, and that just seems, I mean, am I missing something? It seems to be so extremely low. How would he survive?
I think those are absolute numbers, not his percents. Yeah, so 10 to 15 for him. 15 is probably right around 50% for him, diffusion.
That explains
it.
Thank you.
Yep.
When I would go in prior to transplant, my antigen levels kept changing. And at one point, the doctor looked at me and said, "Have you had a blood transfusion?" I'm like, "No." So I'm wondering how that happens, because they kept rising, which he said kept meaning that I was going to, my list of candidates would be smaller. So how does somebody...
This is awesome, actually, because I will tell you that what you're bringing up is, I think, one of the most challenging concepts and constructs for all transplant centers. So the fact that you keep going back to this PRA and my antibodies are changing and like, what do you guys do about it? Part of the reason that I struggle with how best to answer for you all is that there really is not standardization of practice. And there's not standardization of practice because it's not entirely clear. So the way that we identify those antibodies is it's an assay that has these little beads, and we put your blood over the top of it, and the beads have those antigens on there. And so if things stick to those beads, it will then give it a fluorescence intensity. It makes it light up a little bit. And so you may have heard the term MFI is something. They might say, well, you got like a MFI of 200. That's one that we don't really care about. But an MFI of like 100,000, that's like through the roof. The other thing about that testing is that the first pass of that testing, the beads are not specific. So it's not identifying one particular antigen or one particular site that it binds to. It's actually a group of things on that bead. So we will then do subsequent testing to identify the very specific thing that you have. And it starts to get even more complicated because there are ones that are related to each other. So there are aspects of those things that stick up and identify on those cells that there's groups of them that are related together. So we know that if you have like 2 of one particular type, you actually might have the 5 others too. And so the lab that figures that all out, if they start telling you some specific numbers, and if it's a person who's not savvy about this stuff, which honestly, my HLA lab, when they talk to me, my eyes kind of glaze over a little bit, and I'm like, what's going on? But so you can get one number from them, and then when the HLA lab talks about it, they're like, no, these are actually all related to each other. So even though, B7 didn't pop up on your assay, that actually, if we put B7 in, that's really bad. So you'll get these sort of crazy different answers depending on who you talk to and when you talk to them, and that's really what selection committee is for. We go over all of that in selection committee when we have someone on the list. It's really, really complicated, and it's definitely a challenge. It is a challenge to transplant, no doubt.
Yes.
I have a question about the insurance issues. Have you found any difficulty in getting patients that are in a managed care program referred for transplantation versus not?
Sure, maybe. So I think you all in the room will. So I'm always kind of entertained when people don't want the government to control their health care. I'm not sure that I want the government to control my health care either, but our health care is being controlled by people that are not us. That is a reality for all of us. Our insurer, whoever it is, actually has a lot of control. So the thing that I see more commonly, maybe not the referral, but I can have someone who lives in Charleston, a block away from my hospital, and their insurer can tell them that they have to go to, to Boston to get their transplant, because that's their preferred center. And they won't pay for them to live next to the transplant center. So yes, I do think that insurance companies influence things. But the actual referral itself, I think there's other challenges to referral. the sentiments of I do think that there is a segment of the community that just doesn't think lung transplant is really a good thing. A lot of those folks, in my experience, are people that may have been exposed to transplant in the 90s. Transplant in the 1990s, it was a different animal than it is today. We are much better at it.
We'll take one more question.
My brother is being evaluated next week, actually, at Cleveland Clinic for lung transplant. And one of the things we've learned is there's, the term, I think, is increased risk donor.
Yeah.
What is your opinion on those, and is that a viable option for folks?
Sure. So I'll actually expand on it. I'll talk about hepatitis C positive donors too. So because Cleveland Clinic, I know, does hepatitis C positive donors as well. So there's something that's called the Public Health Service increased risk. So it's unfortunately sometimes flip that to that it's high risk. It's not high risk. I don't think any of us would think it's high risk. The greatest risk of a Public Health Service increased risk donor, and what they're worried about is risk factors for hepatitis C in particular. So it's all the behaviors that are, sex for money, sex for drugs, IV drug use, all of these factors that increase your risk that you're going to have hepatitis C. If you have that in your background, then you get labeled as a PHS increased risk. The reality is we are absolutely in an epidemic of drug overdose, and the reality of that is that we do have a lot of donors that become donors because that they've overdosed. So PHS increased risk, depending on what program and what portion of the country you are, it can be as many as 4 out of 10 donors that get accepted from a program. So it's pretty common. And the risk in that cohort, we do all sorts of blood testing on them, and they're negative for those things, but there's that window. So if they just injected themselves with hepatitis C, the risk is about 1 in 300 that you might get hepatitis C. So it's actually I like to use the example of blackjack. If you could win blackjack 299 times out of 300, you would probably not get up from that table ever, right? So our counseling to our patients is, PHS increased risk. If we think that that's a good donor for you, we don't really think of that as a high risk. It is an increased risk, but it's not a high risk. So then the other donor population that's becoming more common is hepatitis C positive donors. So where we'll actually take an organ that we know has hepatitis C, and we'll go ahead and we'll transplant it. And we do that because we have a therapy now, good therapies, actually with an S on it, good therapies that will cure hepatitis C. So we take that upfront risk that it's okay, we're going to get a great set of lungs, we're definitely going to infect you with hepatitis C, and we're definitely going to treat you for it, and everything's going to be okay. And there's more and more data out there that is a strategy, and my belief system is that in about 5 years, that's not even really going to be something we necessarily consent people for. We're going to just say it's just a thing, and we're going to treat you, and this is how we're going to get organs for you. The current process, though, is to really make sure everybody understands very clearly what we're doing and what the process is after if you get hepatitis C.
So on that note, I'd like to express my profound appreciation to the panel for sharing their experiences with us from a patient standpoint and from a clinician standpoint as well. And above all, to you in the audience for joining us for this session today. Thank you so very much.